Good morning. Very good morning to one and all. I welcome all of you on behalf of Cornea Society of India. So, I'll start with my talk on pterygium and cataract surgery. I know it's quite simple thing for all of us. This talk is mainly for general ophthalmologists, comprehensive ophthalmologists. Feel free to give your inputs here. Cataract surgery is already a refractive surgery, and the outcomes as well as the technique has been refined so much that the outcomes are so much predictable. So can pterygium surgery also be a refractive surgery? Well, let's see. When do we operate the pterygium? There are certain indications of pterygium when we need to operate that, when it's significantly large in size, like more than 2 mm on the cornea, when there is a corneal astigmatism there, when there is a progression towards visual axis, cosmetically patient. Okay, thank you. Wants any symptomatic relief, or there is any restriction in ocular motility, we have to remember before it reaches visual axis, we should do the surgery, because whenever it increases in the size, it leads to significant irregularity and refractive changes, and by that time, we possibly would have lost a chance to operate a clean-cut case. Some of the groups suggested that when there is more than 45% of the radius, horizontal radius from center of the cornea to the limbus, we should do, or in short, central 3.2 mm visual axis. When if it's involved, it's better to do it off there. Beyond that, it may not serve the purpose, and beyond that, it may not be very predictable. So when we are planning cataract surgery along with pterygium surgery, the first thing comes biometry. So what do we do? Keratometry, corneal topography. Unfortunately, keratometry is not the best technique for pterygium related cataract cases, because pterygium being a fleshy tissue on the surface leads to unstable tear film, and hence the Myers may not be very accurate. However, in keratometry you do get some reading which may not be very accurate. In that case, topography actually gives you much better outcome and detects the curvature of entire cornea, and even smaller irregularity can also be detected. Among topography also, we know that placidus based topographer are based on the principle of first per inch image, which comes from the reflection from the tear film. Hence, small tear film abnormality, which are quite common with pterygium, may get quite annoying in terms of your keratometric outcome, whereas Schimflug based topographer would do better in that sense. It does not mean that everybody needs to undergo Schimflug based topography, but if you have it in cataract surgery with the pterygium, this is something which is very interesting and important. Topographically, pterygium normally leads to with the rule astigmatism. However, when the pterygium increases in size, it can lead to quite significant irregular astigmatism. Sometimes, as you can see from here, the astigmatism is quite asymmetric, and asymmetric astigmatism gives quite asymmetric results. The induced astigmatism earlier in cases of early pterygium is reversible, but when the scarring increases, these things may not remain that reversible. So what do we do first? Do we do both of them together, or we do pterygium first and cataract together? I'm going to give you an example. One of such case had significant pterygium, was posted for pterygium surgery, and look at the topography post-operatively. Pre-operatively, apparently there was 8.3 diopter astigmatism, and if you do not do topography, and if you just do keratometry, you possibly would end up missing out an asymmetric astigmatism here, quite significantly asymmetric. And post-operatively, it reduced to 1.6 diopter. Now, not only that, there is a reversal of topography here, and in the same area, there is almost change of 13 diopter post-pterygium surgery. So, such kind of significant astigmatism, if we try to treat it without taking care of pterygium, it's definitely not a great idea. So, sequential surgery where we do pterygium first, it's better because of better stability of corneal curvature, high predictability of IOL power calculation, and it allows cornea to heal completely. So when do we do first? Well, always best practice, do pterygium first. Larger pterygiums affecting vision, inducing astigmatism, pterygium first. When do we do simultaneous? Do we do simultaneous? Preferably not, but sometime if pterygium is very small, older age patient, you may not want to do multiple surgeries, low astigmatism, regular Myers on your keratometry, we still can do it. So simultaneous surgery, small pterygia, older patients, reduce hospital visit, and if the cost is a factor, we can think of that. So what's the time gap between, ideal time gap between pterygium and the cataract? Ideally, whenever you do pterygium surgery followed by the cataract, you have to make sure your topography as well as keratometry is stabilized. So keep measuring topography at various follow-ups. Typically, a smaller pterygium, 2 to 4 millimeter a month is good, but make sure you check the topography, and if it's stable, then you go ahead and do the pterygium surgery. So if the pterygium is smaller, it's fine. 2 to 4 millimeter is fine. More than 2 millimeter, well, you might have to wait for 3 months. And if the pterygium is very large and if it's extending into pupillary area, well, you must do pterygium surgery first. Make sure the ocular surface is stable. Make sure your topography is stable. Make sure there are no scarring. And if you have scarring, you might want to take care of that by your PTK or whatever laser procedure you want to do, and following which you plan cataract surgery. So can pterygium affect the biometry? Certainly it can affect biometry, because the larger pterygium can affect the center part of the cornea also, so that 3 millimeter zone can get affected. One nice study by Mustafa and colleague and showed that pterygium size can affect the lens power calculation. So if the pterygium size, which is calculated from the limbus to the head of the pterygium, if pterygium is more than 2 millimeter up to 2 to 4 millimeter, well, 0.5 diopter change can occur in IOL power calculation. More than 4 millimeter, it's better to take care of the pterygium first and do not assume anything. So sometime if the pterygium is less, you may end up in change in keratometric value, and you might have to choose 0.5 diopter less than the most emmetropic power which you have selected. This is to compensate for the change in the keratometry what you do. So are there any change in the surgical technique? Of course not. We can do the regular surgery, but we probably would avoid extracapsular or SICS, because we do not want to affect the limbus there, which might be required for the pterygium surgery, or previously pterygium surgery would have damaged that limbus. We may not want to go on that side. So ideally, well, we operate from the opposite side of the pterygium, and if it's a bi-headed pterygia, we take care of that first and then put an incision superiorly. To improve the visibility, we can use trypan blue. Choice of IOL is simple. Well, you can take care of any IOL of your choice, provided you are not dealing with significant astigmatism. If there is irregular astigmatism, certainly you would want to wait. So when you do pterygium excision, repeat keratometry topography 4 to 6 weeks. Repeat one more time, 2 weeks apart. If there is no change, well, you can surely go ahead with your regular IOL power calculation. No significant astigmatism, no demonstrable higher order aberration, no central corneal scarring, any IOL is fine. But if you have regular astigmatism, you can think of a toric IOL also. But the large pterygia with high degree of corneal aberration, you may not want to do your multifocals here or torics here. So one such case, with that I'll be finishing, that you can see there pre-operatively there was astigmatism which was little high, but post pterygium surgery, not only it reduces, but it actually becomes pretty uniform cornea. So small looking pterygia which are quite inconspicuous still may do quite significant change on the ocular surface. Thank you very much.